So the topic for the presentation today, so we have half hour, and I want to make the best out of your half hour. So I decided to organize this into 3 questions. Those are the 3 most popular questions I get asked in the clinic. And hopefully by answering these questions, can you hear me from the back? Yes, okay. So hopefully by answering these questions, you get a sense of the importance of education in the care of multiple sclerosis. I always tell my patients the first step for your treatment is knowledge and education. When you know what is happening, when you know what to expect from certain therapies and certain approaches, you not only are more engaged into your care, but also you get a better sense of why are we doing what we are doing. So we'll have 10 minutes at the end to also allow for some questions. So feel free to raise your hand, and we'll try to address those questions. So I thought to organize this in these 3 main questions. What is MS, and why is this happening to me? Why should I have an MRI? And what is the best treatment for me? So to answer the first question, you are not alone. MS is a common disease. Over 400,000 Americans currently have a multiple sclerosis, and in the world is growing, currently close to 3 million people. So this is a little bit old, that's a year old. So 80% of patients with MS will have their first symptoms between the age of 16 and 45 years old. The female-to-male ratio continues to be high, so more women compared to men will have multiple sclerosis, and that's approximately for every single man with MS, there is 2.5 women with multiple sclerosis. So these outcomes are outcomes coming from natural history studies, meaning patients with MS that did not receive any therapy, patients that just simply were followed over time, and those studies, as you can imagine, were done in the 50s and 60s when we did not have any therapies available. So we know that of those patients with multiple sclerosis, 50% will require some sort of assistance for ambulation, whether that's a cane or crutches, in 10 years from onset of the disease. 30% of those patients will become wheelchair bound, and usually the lifespan was decreased by 5 years. The good news is that today's numbers, actually, life expectancy is exactly the same as patients without multiple sclerosis. So this is a concrete outcome, an outcome that we should all be proud of, that what we used to say that MS will make you live 5 years less, now that's no longer true, and that's due to the fact that we have treatments available for this disease. So as you all know, healthcare cost is extremely high, and that has to do with direct cost of the medications and treatment, but also indirect cost of having patients that because of disability, they don't work. And as you know, MS is the leading cause of disability in young women, and it's the second leading cause of disability in young men in the United States. So what causes MS? We don't know. Probably it's multifactorial, meaning that multiple factors will play a role in causing the disease. We know that 10% of patients with multiple sclerosis have a first-degree relative with MS, meaning if there is a genetic component. But that genetic component is not that you will inherit the disease. What patients do is inherit a susceptibility of the immune system to respond to certain antigens, certain viruses, certain pathogens in the environment that will make that immune system more likely to respond to antigens in the brain. So it's just a combination of factors. You have to have the combination of the right genes, with the right antigen, with the right environment, and the immune system that responds to all of those factors that will lead to that abnormal response between the immune system and the brain cells. So the prevalence of MS continues to grow, and there is a geographical distribution of that prevalence in the world. Overall, it's approximately 30 per 100,000. In the US is higher, is approximately 100 over 100,000, meaning 1 in 100. In Colorado, it's approximately 1 in 500. We do not know the reason. The reason probably is, as I mentioned before, is multifactorial. It's been speculated that vitamin D deficiency increases the chances of certain populations to develop autoimmune disorders in general, particularly multiple sclerosis. sun exposure will be directly related to that. Though in Colorado, we have a lot of sun. So the question still remains unanswered. Probably with large base studies, there was one very interesting question before asking what happened with these small studies duplicating information in the world. Do we have any large-scale study? And the answer is yes. We are part of a trial called Accelerated Cure Project, or ACP. That's an initiative that is international. We are one of those centers. And that study, what it's trying to do is capture data, information, questionnaires, blood samples, spinal fluid, to try to understand, is there any pattern of disease that is different in Colorado to Denmark to South America? And we are part of that initiative. We have currently 45 patients enrolled. We are moving to the next step of that study, and we always welcome patients that want to volunteer. There is no treatment, it's just simply gathering information, and also healthy volunteers, so spouses or health caregivers. So this is the representation of MS prevalence, meaning the total number of patients with MS divided by the total number of the population. And as you can see, the red and the pink are places with a higher prevalence of multiple sclerosis. So it's been speculated that there is an altitudinal type of distribution of prevalence in the world. And above the 40th parallel, there is an increase in incidence and prevalence of multiple sclerosis. And the same is true in the southern hemisphere. So New Zealand and Australia, and in Patagonia in South America, there is a higher incidence and both prevalence and incidence of multiple sclerosis. But this study is interestingly from the 90s. A recent study from 2012 argues against that altitudinal difference. The main reason for that probably is because of migration patterns. As patients move from low incidence area to high incidence area, these numbers start to become a little bit more contaminated. And interestingly, there is a socioeconomical factor that also predisposes certain populations for multiple sclerosis. It's been entertained the possibility that a high incidence of infections early on in life might make the immune system a little bit stronger and less autoreactive. And that's why in places with poor sanitation like Africa, the incidence of autoimmune disorders is lower. This doesn't mean that your kids should not be vaccinated. This doesn't mean that you shouldn't wash your hands. You should do that. But it's interesting, like, that socioeconomical factor might play a role, and this is just simply speculation. And when you look at migration patterns, the reason why people with lower socioeconomic status migrate is different to the reasons why people with higher socioeconomic status migrate. The first group usually do it in the basis of work, and that's usually north and to climates with less sun exposure, while people with higher socioeconomic status usually migrate south in warmer climates. And that's why all of those factors are somehow changing the geography of multiple sclerosis in the new era. In the US continues to be similar, but you see both prevalence and incidence continue to grow. Incidence, the difference between the two incidence means the new cases of multiple sclerosis on a population that is susceptible, whereas prevalence is the total number of MS patients in the same population. So both are growing, and probably is a reflection of the disease also being more common, but most likely that is also a reflection of physicians being more comfortable with making the diagnosis of MS and having the criteria of diagnosis being a little bit more specific and sensitive, allowing us to diagnose MS more frequently. The female to male ratio continued to be also growing. It seems like more female patients are being diagnosed to men compared to what it used to be, but it's still around in between 1.5 to 2.5 female to 1 male ratio. And there are many speculations on that. Probably the fact that women are also working and exposed to healthcare, it's also could be the reason why women are more often diagnosed. And interestingly, I read somewhere in one study that they talk about socially men, we try to report our symptoms, and they even talk about this machista attitude that we don't want to recognize that we have weakness or we have numbness or we have all these things, leading to a late diagnosis. So don't get offended with me. I read that somewhere. It's not my interpretation. So So that hopefully answers the basics on what is MS, what is the distribution of MS in the world, any risk factors. We unfortunately don't know the cause, and the speculations that we had 10 years ago are probably the same we have now, plus minus some new information. But yes, the answer is going to be in large scale studies. So we always talk about two phases of MS. One, and that's in every patient, whether it's relapsing onset multiple sclerosis, progressive onset multiple sclerosis, what we used to call primary progressive, relapse and remitting secondary progressive. Probably MS is MS. It's the same disease that will manifest differently in patients depending on a variety of factors, whether it's access to healthcare, recognition of symptoms early on, whether the lesions that patients have will affect eloquent areas of the brain causing relapses early on. But when you put together the disease as a one entity, you can recognize in all patients two well-distinct phases. One is what we call inflammation. And as you can imagine, if inflammation is driven by your immune system, the younger you are, the younger your immune system is, the higher the chance of damage that immune system will have when the immune system interact with your brain. And that's why early on in the process, in the first 5 to 10 years, is when we see that immune attack to the brain is very active. And there are many consequences of that. Those are the three most common ones, which is lesions in your brain or spinal cord. In a patient with MS without treatment, we expect to see anywhere from 5 to 10 new lesions every 18 months. That's again without treatment. And that's particularly true in the first 5 to 10 years of the disease. Relapses, one relapse approximately every 18 months. And you can make a couple of conclusions, but the most important one here is that, as you see, only 1 out of 10 lesions in general will cause symptoms or relapses. So lesions are more frequently asymptomatic, and eventually one of those lesions is going to affect an area of the brain or spinal cord that you need to work today or to move or to think, and that's when you have the symptoms, and that's when we call them relapses. So lesions are more frequent, and 90% of the lesions are asymptomatic. That's already giving you one of the answers of why we need to do MRIs, right? Because even if you feel fine, even if we do an exam and looks unchanged, it's not unusual that patients will still accumulate lesions over time. So these two factors likely drive disability, and that's seen very, very early, even after the first attack. When we do a very sensitive test for cognition, for ambulation, we see that patients already accumulate disability from day one of diagnosis. So those are the consequences of inflammation. Your brain is smart, and your brain will try to fix that, and there is a process of regeneration, and that's natural. We don't have therapies currently that we could enhance that, but as you can imagine, if you have a system that is going to repair damage, if you have a city that you have people that is making mess in the city, and then you have people that is cleaning up the city, one of the first steps to enhance the people who clean the city is to get rid of the ones that makes the mess. So one of the first steps to enhance regeneration is to stop inflammation. So that's why, indirectly, all of our anti-inflammatory therapies somehow are allowing your brain to regenerate by itself. So the second phase is what we call degeneration, and that's been a classic controversy in the field of multiple sclerosis, whether inflammation drives degeneration or whether those are two separate entities. More and more, the recent publications are suggesting that they are not independent of each other. And we would like to believe on that, because you know that if you could affect inflammation very effectively early on, not only you will allow for your regeneration from natural pathways, but also you're decreasing your chances of continue that degeneration. And what are the consequences of that degeneration? Well, when that accumulation of problems reach certain thresholds, that's when patients start to feel, I was fine with my MS for 10, 15 years, but now I feel that it's more difficult to think, more difficult to remember, to walk. If I try to do something outside the ordinary, I feel the consequences. And that's when we in the clinic like to label, not myself, but we, in general, label patients as secondary progressive multiple sclerosis. But as you can see here, it's just the same disease, the same spectrum of disease that goes through different stages. So the consequences, I mentioned some, but the most common one being fatigue. That's both mental fatigue and muscle fatigue. The mental fatigue is the one that you feel that after a certain amount of mental activity or cognitive activity, you're done. You just hit a wall and you can't function anymore. And I always try to tell my patients, well, if you have a brain that is asking you for rest, would you keep that brain a psychostimulant so you can work more? No, probably you will give that brain a rest. And it's always good to keep your brain active. It's always good to engage into cognitive activities, but do it in moderation and do it in small steps, and don't reach that moment in which you hit a wall. Try to take a 5-minute break, go for a walk, maybe take a nap, and go back to your activities. So those are more natural ways to deal with fatigue. And exercise is probably one of the most effective and safe and relatively inexpensive also way to deal with fatigue. We know that exercise is one of the best ways to enhance regeneration and cortical plasticity, and I have a slide at the end that will summarize that as well. Cognitive problems and more disability, those are the unfortunate consequences of degeneration. So hopefully this gives you a framework to understand, first of all, what should we expect in a patient per natural history without any type of interventions. And also that gives you an idea of comparing yourself now to what would have happened if you didn't have that intervention, to try to answer that question, is my therapy working? Is my therapy giving me any type of benefit? So this tries to summarize a very interesting study, probably one of the most complete natural history studies ever published in the group in Lyon, France in 2003, and they just simply follow patients for years. And that tells you, again, that MS is MS, is one disease, and every patient is absolutely different. And if we try to group patients into these fixed categories of primary progressive relapsing, we probably are doing the wrong thing. And what they concluded is that the way patients start, whether it's relapsing onset or progressive onset, is just a matter of time. But once any patient reaches a certain amount of disability, the progression of the disease continues a similar pathway that is independent of the type of onset, and they call it this amnestic prior to the clinical onset. So it seems like once patients reach decane, whether they started with relapses or whether they started with primary progression, that doesn't matter anymore for the brain. The brain will continue to follow an MS the same type of evolution. That's without therapies. And that's why it's very important in our therapies, the first day I meet with my new patient, to go over these data and to try to say, we need to do anything we can to avoid the cane. Even if you get to the cane, we need to do anything we can to avoid the wheelchair. And if we reach the wheelchair, we need to avoid anything we can to try that wheelchair is going to significantly impact the way you function and you live your life. So why should I have an MRI? So we already answered the most important question, to try to identify that asymptomatic activity in your brain and spinal cord. 90% of lesions in the brain are asymptomatic. In the core, it's less frequent. The core is very tight. All the wires that come from your brain are going to get in a small little cylinder in your spinal cord. So even a small, tiny lesion in the core most of the times will cause symptoms. It's prime real estate. It's downtown. If you have a car accident in downtown, everybody will know about it. If you have a car accident in Tabernash, probably 10 people will know, and they will just laugh about it because they have so many other ways to go around that car accident. So it depends on the location. So lesions will cause symptoms depending on many factors, size, and all these different things, but location is key. It's like in real estate. So this is what a typical brain MRI will look like, and probably all of you are familiar with that because at some point you had one, and your doctor probably reviewed that with you. That's a horizontal cut in the brain. And what you see as gray is the normal tissue. What you see as white dots are those areas of demyelination or loss of myelin. Not infrequently, patients ask you, what is that? Why I see white dots? Well, that's just simply water. For the MRI machine, your brain is just fat and water. They don't distinguish much about that. So the more fat you have in the given tissue, the darker the signal will get in this particular sequence. The less fat that you have, the brighter the signal we get in this particular sequence. So if you have a 50% fat, 50% water, you get a gray signal. If you had less fat because you had demyelination, water will take over, and you have 20% fat, 80% water, you get a white dot. So what I tell my patients is white dots is just simply water. Indirectly, we know that is a representation of demyelination or loss of fat in your brain. So does the MRI machine matters? Yes. As you can see here, this is the same patient at the same time having the MRI done in 2 different machines. 1.5 Tesla, which is a measure of the strength of the field of the MRI, versus 3 Tesla, or the 3T that you see here. And you see that in the 3 Tesla MRI, you see more lesions. So not infrequently, patients will change MRIs over time, and then we get confused thinking that patients have new lesions, but indeed, the only thing that changed was the strength of the field of the MRI. So I always tell my patients, just choose one MRI based on your insurance, based on your access, and try to stick with the same MRI over time, so we don't get confused by seeing more lesions just simply because the MRI machine is better. It's like cameras and photography, the same concept. So an 8 Tesla MRI, that's fantastic. It's not clinically available. It's only available for research because apparently the field is so strong that makes patients dizzy, and of course physicians dizzy too. So it's not available for clinical practice, but with an 8 Tesla MRI, you can see cortical lesions that we never thought MS patients had. We always talk about Weimar disease. Well, that's old. It is also a Weimar disease, but the disease clearly affects the cortex, the outer layer of the brain. That's where your neurons are. That's where your brain cells live. Those are the cells that allow you to think, to move, to remember things. So, affecting the pathways, it's bad, but affecting where the neurons live is worse. And that's why cortical lesions are becoming this area of interest among all researchers, particularly MRI researchers, to try to understand, A, why they occur. Is there any pattern of patients or any type of patients that have more cortical lesions, and why is that? We don't know yet the answer. And B, what are the consequences of that? And as you can imagine, cognitive problems is probably one of the most common consequences among those patients. The other concept that I want you to be a little bit more familiar with is black holes. And I'm sure all my patients know about black holes because I tend to be obsessed about them. But I want all of you today to learn about them. Black holes are bad news. As the name implies, it's a horrible name, but somehow gives that negative sense that I want to convey today. We talked about demyelination causing white dots. And look at your brain as a bunch of nerves. And each nerve is like this wire that I have here that I will not touch because somehow I will disconnect the microphone. But imagine this wire is a brain, a nerve. You have 2 components. You have the myelin and you have the axon. Like in the wire, you have the plastic and the copper wire. The plastic around the nerve is the myelin. The myelin in the nerves not only will protect the axons, but it's also where the information travels. The information to the brain, to the body, and from the body to the brain will travel. So when you lose myelin, the conduction is going to get slower. And if you put that axon, that nerve in the MRI, you get a white dot. But what happens if you lose myelin and axons? Let's say that the immune system came not only attack the myelin, but also attack the axons, causing a transection of the nerve, literally cut the nerve. That's when you get a black hole. So black holes are areas that the immune system went to the brain, causing a deeper lesion. And why I get obsessed about that? Because in order to remyelinate, in order to repair, you need to have an axon. If you don't have the axon, there is little or limited chances for repair. So black holes are areas that I look at them and I think, geez, we lost that battle to that lesion. We need to do something before this process continues causing black holes in your brain. So we talked about the consequences of demyelination, but I want to make it very, very practical and clear and concrete for you. So if you imagine that your brain is a bunch of nerves, and each nerve represents a different street in a city, and we just talk about Denver as your brain, And let's say you want to move your finger. Well, the brain will have to go from Aurora to golden, from the brain cell to the finger. There is a pathway there. Let's imagine that in that pathway, MS causes a lesion. Well, that pathway is going to be either interrupted if there is a black hole, or it's going to get slower if there is just demyelination. Your brain is smart, particularly early on. So your brain is going to say, well, let me take another route. And for years, you're going to be taking that other route to move your finger. That's called cortical plasticity. Well, let's imagine that now MS hit that route again. Well, you may have a relapse if that's very acute, but then you repair. And the repair is partially try to fix that blockage, but partially is also try to find another pathway to get to that finger. So because the pathway now is longer, it's like when you do a GPS that gives you 3 options, and usually the first one that recommend is the longest one. And that's the one I typically follow. The third option is going to be the longer one in this case. The brain is very lazy. The brain tries to do as much as the brain can with a minimum amount of effort. Why is that? Well, the energy that the brain has to make you go through the day every day is equivalent to the energy that the refrigerator needs to have that little light bulb inside. So it's a small amount of energy. So it's extremely efficient. The brain does amazing things with a minimal amount of energy. So it's always saving energy. So it's always trying to find that shorter pathway to reach what I have to do. Well, you have the third option, but let's say you just have another MS lesion there. Well, that's when disability occurs. You don't have as many options to compensate for that loss of brain parenchyma that MS is causing. So, and this is probably the most clear representation of how the brain is compensating. In the left, you see I have left-right disorientation, so don't ask me which one is which, but the smaller orange dot, that's a normal patient, a patient without MS, trying to move a finger. On the right, or the larger a red and orange sign, is a patient with MS doing the exact same thing. As you can see, that has to recruit more cells to try to accomplish the same amount of activity. So that's another cool MRI that will actually follow the tracks of your brain to try to see how much demyelination is on those tracks. We don't have this available clinically, but it's extremely interesting for research. So I will move away from that, unfortunately, and I will come to the last piece that I want to talk, unfortunately. That is, how do we know your therapies are effective? Well, we look at the same outcomes that I was talking to you before: lesions, relapses, and disability. And based on what we expect a patient should go through by natural history, we then try to have the conversation with the patient. Which therapy should we choose that is going to be right for you? So the past history is very important. If I have a patient that before I saw the patient was having anywhere from 5 to 10 lesions, every time the patient had an MRI, very active, causing a lot of problems, I know that we need to go to the big gun to stop that. But also a patient, you may argue, well, what if I have only one lesion, but it's causing significant problems to me? Again, we have to go to the big gun. So every time we meet with a patient, we try to individualize the care to what their needs are, the lifestyle is, safety concerns, any comorbidities that might make some medications less attractive for that particular patient. So safety and efficacy are very important measurements that we take into account with every single patient. When you look at clinical trial data, and most of this data is driven by MRI lesions, you could group, in terms of efficacy, the medications into 3 main categories. Natalizumab or Tysabri is a once-a-month intravenous medication approved in 2005. Rituximab is also an intravenous medication not approved by the FDA, probably will never be approved, but a similar compound of this medication is currently being under investigation called ocrelizumab. That's an anti-B cell therapy. and unfortunately couldn't go through the cartoon that I had, but B cells are those cells that we want to stop because those are the ones telling the other cells, the T cells, what to do, go to the brain and cause lesions. So B cell therapies are becoming very, very, very popular because it's probably another area of targeting with our therapies. Rituximab is every 6-month infusion, as I mentioned before. It's not FDA approved, but we can still use it. We have quite a lot of patients in our clinic on rituximab. If you go down in terms of efficacy, you could have the 2 new oral therapies, actually 2 of the 3 new oral therapies, Gilenya and Tecfidera. Gilenya approved in 2011, plus minus. Tecfidera approved March 2013. Gilenya is a once-a-day oral therapy. Tecfidera is twice daily. Each of them have their own safety and tolerability concerns, which I suggest you to spend a few minutes with your doctor talking about them and being very, very educated about that. And if you go down there in terms of efficacy, you have Aubagio, also an oral therapy, once daily, approved in 2012. And you have the interferons and Copaxone approved back in between the 90s and early 2000s. So this is just in terms of efficacy. In general, as you move down in terms of efficacy, you gain in safety. But safety, each of these drugs will have each particular safety concerns. We have more biomarkers now that we can check, for example, the JC virus test, to see at what category of risk you are to receive, for example, Tysabri. We can do some pre-screening labs and EKGs to see at what category of risk you are to receive Gilenya. So each of them will have their own story and impossible to cover in half hour. So I apologize, I don't have too many details. But this is just to give you an idea of, in terms of just efficacy, how are these therapies could be grouped. So just to summarize, and I apologize I didn't cover the immunopathogenesis of MS, but I'll be glad to answer any questions. MS is a chronic disease. Probably the take-home message for you today is, even though the disease may be the same, every particular patient is different, and therapies should be individualized to that particular patient's need. The immune system plays a role in perpetuating the disease, but it's probably not the only thing that plays a role. MRI is a key component, not only for diagnosis, but also to establish what type of MS do you have. Do you have a very aggressive MS? How many black holes? How much atrophy? We didn't even talk about atrophy, but the brain shrinks over time. We need to stop that. And also, individualized therapies is probably one of the best approaches. I don't know what the right answer is. I know what the wrong answer is in MS therapies, which is pick up one favorite drug and use it in every single patient. Probably you are wrong. You're gonna be wrong for many, many of your patients. So every time we approach therapies, we meet with the patient, we review the history, do an exam, look at the MRI, and go over all the options and try to decide what is your best therapy for you today. The patient may change over time, and we keep changing that therapy. We try to be as proactive as possible early on, but things may change in the future, and it's up to you and us to work together to stop this disease from progressing. Thank you very much.
Thank you, Dr. Miravalle.